Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Osteoporosis is common as we age. The CDC estimates that 1/4 of women over 65 have weak hip and back bones. This is the People's Pharmacy with Terry and Joe Graydon.
If an older person breaks a hip in a fall, the consequences can be devastating, if not deadly. Many people don't recover from hip fractures. That's why it's so important to prevent osteoporosis.
Keeping bones strong starts when you're young. Exercise and diet are not only essential for heart health and good brain function, they're also critical for building strong bones. What should you be eating and doing to maintain your bone density?
Coming up on the People's Pharmacy, find out how to keep your bones healthy.
First, this news.
In the People's Pharmacy Health Headlines, is it possible to improve the air you breathe on an airplane? Most people realize that air travel increases the chance of catching a cold or some other respiratory infection. That's because air circulation on planes leaves a lot to be desired. Half the air you breathe is recycled within the cabin. The other half, however, is mixed with outdoor air. A high-efficiency particulate air filter catches dust and germs, but you will be exposed to cold or flu viruses if someone coughs or sneezes in your general vicinity. That's why you want to keep the air vent on over your seat. A lot of people find that air too cold or possibly annoying, but it is helpful in keeping germs out of your personal space. The turbulence that airflow creates keeps your personal space cleaner and freer of viruses and other particles. A low or medium setting should be sufficient.
When you visit the eye doctor for a routine eye exam, a key part is checking intraocular pressure. That's to test for glaucoma. This is especially important for patients who have been diagnosed with elevated eye pressure. While many people are accustomed to measuring their own blood pressure with a home monitor, few, if any, glaucoma patients have measured their own eye pressure. A recent study of 100 individuals with glaucoma found, however, that the majority could do so successfully if they received training in the ophthalmologist's office. The investigators point out that self-measurement would allow patients and their eye doctors a better understanding of how their glaucoma was progressing. This, in turn, would facilitate better control of the condition over time.
Most people have heard that melanoma is a very dangerous type of skin cancer. For years, they've been advised to look for any moles that have changed color, shape, or size. But it turns out that a lot of melanomas occur in spots that did not have moles previously. A review published in the Journal of the American Academy of Dermatology found that fewer than 1/3 of melanomas start in existing moles. Of the 20,000 skin cancers that were included in the analysis, 71% started as standalone lesions. These melanomas tend to be more aggressive than those originating around moles. People need to pay attention to anything new or different that shows up anywhere on their skin. One rule of thumb is to look for A, B, C, D, E. Those letters stand for asymmetry and border irregularity. That means the spot is uneven. C stands for color variability. D is for diameter, bigger than a pencil eraser. And E is for evolving. That means the spot is changing. A dermatologist should evaluate any such lesions.
Chemotherapy saves lives, but it can also result in long-lasting side effects. 2 new studies show that women treated for early-stage breast cancer may suffer from the numbness, tingling, or pain of peripheral neuropathy in their feet for years afterwards. Relatively few studies of chemotherapy effectiveness actually follow up on such side effects, which can have a big impact on quality of life. To determine how common peripheral neuropathy might be, The investigators examined data from more than 1,500 breast cancer patients in the National Surgical Adjuvant Breast and Bowel Project Protocol B30. After 2 years of treatment, about 42% of the patients reported neuropathy, with 10% in severe pain. The analysis showed that lower-dose docetaxel combinations were less likely to trigger peripheral neuropathy. However, older or heavier patients appear to be more vulnerable.
Anxiety can affect children as much as adults. It's estimated that anywhere from 15 to 20% of youngsters suffer from debilitating anxiety. A review of 15 studies that included more than 7,700 children found that SSRI-type antidepressant drugs like sertraline or fluoxetine, Prozac, worked better than placebo to alleviate symptoms. Benzodiazepine medications such as alprazolam, Xanax, used to treat anxiety in adults, did not work. But cognitive behavioral therapy was quite effective. It helped more than fluoxetine or sertraline and did not have side effects. The investigators concluded that cognitive behavioral therapy is a viable treatment for childhood anxiety. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Most of us take our bones for granted until we slip and fall. If we break a wrist, an arm, or a leg, we instantly become acutely aware of how important our bones are. Immobilization in a cast while the bone heals can be both inconvenient and uncomfortable. How can we keep our bones strong and healthy as we grow older?
To find out, we turn to Dr. Abby Abelson. She's chair of the Department of Rheumatic and Immunologic Diseases of the Orthopedic and Rheumatology Institute of the Cleveland Clinic. She's also the Education Program Director in the Department of Rheumatologic and Immunologic Diseases.
Welcome to the People's Pharmacy, Dr. Abby Abelson.
Thank you.
We are delighted to have you with us today. And I guess my first question, well, it starts sort of as a comment. You know, most of us, we never think about our bones unless, A, something breaks, or B, by accident, we get diagnosed with either osteopenia or osteoporosis. Dr. Abelson, why should we be paying attention to bone health from an early age?
It's really important to pay attention to your bone health because osteopenia and osteoporosis are preventable. Osteoporosis is a condition that can lead to early fractures or late fractures. It can lead to height loss. Sometimes it actually leads to death. Osteoporosis can lead to hip fractures that threaten our independence. And it's never too early to start thinking about bone health, and it's never too late to treat it. Our bones, as you said, are not something we pay attention to until something goes wrong. So just like we want to take care of the rest of our body proactively with preventive measures, all the things that we do to take care of our heart and our lungs and the rest of our body, we need to do for our bones as well.
What makes some people more susceptible to weakened bones or to fractures?
There are many conditions that make us more susceptible to losing bone density as well as fractures. Sometimes there are things that we can't control, like genetics. My mom had osteoporosis and she fractured her hip in her 60s. I can't control the genetics, but I certainly can control exercise, calcium, and vitamin D intake. The other things that can make people more likely to lose bone are low vitamin D, low calcium intake, smoking. Certainly that is something that we want to make sure that people aren't doing. There are certain medical conditions like inflammatory bowel disease, hyperthyroidism, and some medications that lots of people are on, like prednisone. Certainly, a lot of people are on prednisone and need to be on prednisone, but the physicians who prescribe those medicines are very attentive to the fact that it can lead to early bone loss.
Well, you are, in fact, a rheumatologist and have to deal with people who suffer from very serious pain and inflammation as a result of rheumatoid arthritis, for example, I'm sure. And back in the 50s, your colleagues, you weren't practicing then, but they were in love with corticosteroids like prednisone because, wow, these drugs work such miracles. They got people out of bed and functional, and we didn't have a lot of other options. Unfortunately, large doses of corticosteroids for long periods of time can lead to bone fractures, can lead to weakening of bones. And so how do you deal with that today in the 21st century?
Well, first of all, Joe, you are so right. When early in the 50s and in the 60s, there were lots of patients with rheumatoid arthritis, as well as lots of other conditions like asthma, inflammatory bowel disease, for whom there were no choices. We're fortunate right now that we have lots of other treatments that help us reduce the dose of prednisone. But for people who do need to be on prednisone, we do have medications to help reduce the rate of bone loss. We have medications such as bisphosphonates. We have some other medications, teriparatide, a daily injection, as well as denosumab. All these medications are used by those of us who treat patients with steroid-related bone disease.
Now, before we get into the medications, I'd like to know what anyone can do to maximize bone health at various ages and stages of life. What can we do that isn't taking a medication?
Well, it is really important to attend to all the things that help build bone and maintain our bone density. So right away, we want to make sure that everyone is getting adequate calcium. For an adult, that means 1,200 milligrams a day. I actually advise that most patients get their calcium from their diet. We know that dietary calcium is safe. We used to think that people needed huge doses of calcium, like 3,000 milligrams. But now we know the 1,200 milligrams of daily calcium. And again, you can get that from your diet. And there's lots of online sources that tell you how much calcium is contained in a number of different foods.
Now,
in addition,
let me just pause you right there, if I may, Dr.
Sure.
Abelson. And that is, most people think white. They think dairy. And the only way that they can possibly get calcium is by drinking, a quart of milk a day, or lots of cheese, or tons of yogurt. But it's my understanding you can also get calcium from green leafy vegetables.
Exactly. I was going to say, think green. Kale, broccoli, there's lots of other sources. You have to eat a lot of greens to get sufficient calcium. But again, there's almonds, almond milk. There are a lot of people who have lactose intolerance who need to get their calcium from other sources besides dairy. And in addition, a lot of people are watching their fat intake for cardiovascular health. So again, I think looking online to see if there's other sources such as nuts and greens that can give you adequate calcium. And again, it's 1,200 milligrams a day. And I think if people are really careful about maintaining that, that's really what they need. Now, vitamin D is another story. Certainly, vitamin D is not supplemented in a number of our foods, and it's hard to tell looking at any individual person if they've got an adequate vitamin D. So I usually measure their vitamin D, and if it's very low, sometimes I prescribe vitamin D. But again, there's vitamin D that is in some dairy products that's supplemented. What I tell people is really read your labels and make sure that you incorporate things into your diet that are things that you like to eat, so it doesn't become something that's a chore.
What's so interesting to me, Dr. Abelson, is that there are a lot of studies that show low vitamin D levels can lead to all kinds of mischief, not just with bones, but all kinds of other systems, maybe even in joints and arthritis, for example. But supplementing with huge doses of vitamin D doesn't seem to be very beneficial. You're in Cleveland, and I hate to say this, but the weather is not great in Cleveland in the wintertime. Nobody's going to be getting very much vitamin D. The dermatologists are happy about that because they're saying, yes, stay out of the sun. But is there room for getting a little sunshine on your skin, especially in the spring and summer and fall, as another way of getting vitamin D?
Well, my dermatology friends actually say no, but I do think that, staying consistent with sunscreen still does enable people to get some vitamin D transition. Your skin sunshine does help you convert from the inactive form of vitamin D to the active form in your skin. But again, there are a lot of sources of vitamin D that you can get, and there's a lot of supplements as well. It's interesting that in some other countries in the world, there's a lot of supplementation in margarine with vitamin D, which is an oil-soluble vitamin. But again, it's hard to tell. There are a lot of people who take a lot of vitamin D. For instance, if people are very obese, vitamin D tends to go to the fat, which is kind of like a vitamin D sink, and it's harder to get out. So I think it's good to talk to your doctor about getting a vitamin D level so that we can be sure that you've got adequate vitamin D. And just as I said that you need to get in a lifelong pattern of adequate calcium and vitamin D, people need to do that with exercise. One of the things that is such a threat to our national health in terms of bone health is sedentary lifestyle. We want to make sure that people are, from very early age, get very in tune to staying active, not sitting in front of a computer screen all day long, not being a couch potato watching television. In terms of children, we want to make sure that they understand that good exercise, and when we say exercise, it doesn't have to be going to a gym and working out. It can be merely getting 10,000 steps a day. It can be, taking an hour walk 3 or 4 times a week. One of the things about building bone strength is it just takes a good heel strike, like with a brisk walk. So it's not like we have to go out of our way to do things that are really uncomfortable or otherwise bad for you to really take good care of your bones.
You're listening to Dr. Abby Abelson. She's chair of the Department of Rheumatic and Immunologic Diseases of the Orthopedic and Rheumatology Institute. She's also the Education Program Director in the Department of Rheumatologic and Immunologic Diseases at the Cleveland Clinic. Her book is The Cleveland Clinic Guide to Osteoporosis.
I'm so glad she mentioned exercise, Terry, because that is so critical. And, we spend a lot of time sitting behind computers every day.
We certainly do, far too much.
But we also play tennis, you do karate, we like to take walks, so...
Taking the dogs for a walk is good for our bones as well as theirs.
And, when she mentioned corticosteroids like prednisone or cortisone, those drugs can melt bones, to quote one physician who we interviewed many years ago. And that includes not just oral medicine, but some of those inhalers, like the kind you might use for asthma. They have pretty powerful corticosteroids, so have your bones checked.
Absolutely.
We need to take a break. When we come back, we're going to learn about the importance of exercise, more exercise for your bones.
Bones are constantly being remodeled, and we'll find out how exercise affects that. What kind of exercise is most beneficial?
And how can you tell if your bones are in trouble?
Find out what osteopenia is and how doctors detect it.
Do men need to be concerned about bone health too? If so, what should they do?
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. The website is uddercream.com.
If you would like to purchase a CD of this show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1093. That number again, 800-732-2334, or online at peoplespharmacy.com. You can also download the podcast from iTunes.
Today our topic is bone health. What should you do to reduce your risk of osteoporosis and fractures as you get older?
We're talking with Dr. Abby Abelson, chair of the Department of Rheumatic and Immunologic Diseases of the Orthopedic and Rheumatology Institute at the Cleveland Clinic. She's also the Education Program Director in the Department of Rheumatologic and Immunologic Diseases.
Dr. Abelson, why is it so important for us to be getting exercise throughout our entire lives?
Exercise is critical to maintain strong bones, to keep healthy hearts, to keep our lungs healthy. Every single organ system in our body is dependent on getting regular activity and regular exercise. The thing about bone density is that, again, it doesn't take a huge amount of exercise. I'm not telling people to go to the gym and work out with weights. I just tell my patients to take a brisk walk 3 or 4 times a week for an hour. Again, that good heel strike is important. We want to make sure that from early on in life, kids understand the importance of staying active, and certainly all the way through our elderly patients' lives, we want to make sure that they stay as active as possible.
You know, I think a lot of people have very little sense of bone physiology. It's like, you know, they see old bones and they go, oh, well, that's so boring. I mean, there's nothing going on. But in point of fact, bone is constantly what you call remodeling, right? I mean, it's undergoing breakdown, it's being rebuilt, it's going through all kinds of active phases, and exercise kind of facilitates that process, right?
Absolutely. I'm so glad that you mentioned that, Joe, because people kind of think of taking care of their bodies, their hearts and their lungs, but they think about their bones as if it's rigid like wood and that it's always there. Our bone is in constant turnover, as you said. There's bone-forming cells, there's bone breaking down cells. The osteoblasts are the bone-building cells, and the osteoclasts are the ones that break bone down. If we didn't have that dynamic balance, our bones could not grow. Our bones couldn't repair fractures. So it's a wonderful physiology that helps us maintain bone strength and repair bone and remodel it. But it's also something that we have to think about. I actually draw diagrams for my patients in my office to talk about the balance of these cells and their activity, because they can impact their health of their bone just as they can impact the tissues, the cells in all the rest of their body.
You know, Americans love specificity. And what I mean by that is, you know, you say, oh, just exercise, just go walk. And they go, no, come on. Tell me, what's the best exercise to keep my bones strong? I mean,
that's what some people want to know. And the others want to know, what's the minimum amount of exercise I can get by with?
Right. We want the best and the least. So is like riding a bike okay? What about yoga? Swimming, jumping rope. I mean, give us some guidance, because our listeners want...
Happy. Absolutely. First of all, every single kind of exercise is good in some way or another for bone health. Muscle strengthening is really important. Yoga and balance exercises are really important for fall prevention, because what the literature shows is that most osteoporosis and osteopenia fractures are related to a fall. So I will tell people to do strengthening exercises, balance exercises, in addition to something with a good heel strike, like a brisk walk. Certainly biking does strengthen your bones. It's not as gravity intense as some other things. But I say do as much as you can and actually vary it. I have a lot of patients in their upper 80s who's, because of arthritis or because of other issues, their best exercise is doing water walking. And, it's less pounding on their joints, but it is strengthening their muscles and certainly giving them anytime we do any of those exercise, it does stimulate bone strength.
One of the things that we tend to tell people is find something you like to do, because then you'll actually do it. So whether it's karate, which is one of my favorites, or tennis, which is one of Joe's, or other people love to go dancing, all of that stuff's good, right?
Absolutely. It's great. And I absolutely agree with you, Terry, that the things that you enjoy, you're able to keep up with, patients are able to be, to persist with activities they enjoy, just as it's really important to make sure that your calcium and vitamin D come from foods that you like to naturally incorporate into your diet. Absolutely, the exercise that you enjoy and that you'll stay with for the rest of your life is the one that's best for you.
So we've already established that osteoporosis is bad news, and you mentioned that fractures can cause all kinds of problems, especially for older people. And if you break a hip, that can put you in a nursing home or can lead to early death. So we want to prevent all of that. And I guess my first question in this regard is, well, how would you know if you're in trouble? What's the right way to diagnose osteopenia, and what the heck is that, and osteoporosis? And we've heard that the tests are actually pretty controversial. One of the issues that has come up over the years is, well, who do you test against? What's the control? So if you're a 78-year-old woman and you're getting your first bone mineral density test, are you being compared to other healthy 78-year-old women or a 21-year-old? That doesn't seem fair.
Well, I'm so glad you asked those questions. The gold standard in terms of making a diagnosis of your bone density, the measurement that we use throughout life after postmenopausal patients, is bone mineral density that is tested through a DEXA. That's a machine. You just lie down. It's not painful at all, but it helps measure exactly what your bone density is in your spine and in your hip. And from that, we can predict your individual fracture risk. We usually say that patients should get that somewhere around 60, but a lot of physicians are, if you've got a risk factor, if you're a woman, if you've got a positive family history, if you've got other medical conditions, we will do it around 50, right at menopause. We usually do it about 10 years later for men. But the T-score, which is what you were referring to, compares that individual to a young adult normal. But it's not that we're judging by a young adult normal, it's that we are able to calculate fracture risk. The other thing we're able to do, and I tell my patients to do this, if you Google all capitals FRAX, you can plug in the bone density and calculate your individual risk of fracture in the next 10 years. So we actually calculate for each individual person. We take the bone density and we use the FRAX score, and we can predict if that patient is likely to fracture in the next 10 years. And based on a lot of good data, we're able to tell if patients should be treated or not. And this is a worldwide assessment that has been very helpful.
Now, I'm assuming that if you find someone has a bone density that's a little bit low, but their fracture risk is not high, you go into prevention even more intensely than we were just talking about. So what might be added?
Yes, so Terry, that's exactly right. So that's a patient probably with osteopenia whose bone density is slightly lower than we might expect. First, the thing that we do is we assess whether there's other secondary risks. We look for their vitamin D level. We have them fill out a calcium questionnaire. We'll probably test their thyroid function. The other thing we'll probably test is to see if their parathyroid gland is functioning properly. The parathyroid is a small gland next to the thyroid that controls calcium metabolism. We might screen for other conditions as well. And once we make sure that none of those conditions are problematic, we will make sure that they are getting certainly we always want to make sure they're getting adequate exercise, and we'll be a little more aggressive about calcium, vitamin D, and exercise compliance, and we will make sure that the patient's doing that. And then we'll follow them. Sometimes we'll follow a urine marker or a blood marker that helps us calculate bone turnover. But again, we kind of individualize the approach. Frequently, we'll just have them step up their exercise a bit, and then we'll follow their bone density a couple years later.
Could you explain, please, why the thyroid gland and the parathyroid gland are both so important?
Yes. So the thyroid gland, if it's excessively producing thyroid hormone, hyperthyroidism tends to decrease bone density. The parathyroid gland that's right next to the thyroid controls everything related to calcium metabolism. And again, these things may be totally asymptomatic, but some people may have hyperparathyroidism, and the excessive production of parathyroid hormone from the parathyroid gland can lead to very rapid bone loss and fractures as well. So that's why it's good to have your doctor look for all these things and not just, I think it's important to look for secondary causes before we just put somebody on treatment.
And that's why it's so critical to get the thyroid dose just right, because if a woman were taking a little too much thyroid over a long period of time, that too could lead to increased risk of osteoporosis, even if she's hypothyroid.
Yes, Joe, absolutely. Excessive thyroid replacement is a risk factor for losing bone as well. I'm glad you brought that up. Thank you.
Now, what about men? We've been talking a lot about women, and nobody ever stops to go, well, yeah, men can get osteoporosis too, especially men with prostate cancer who are having their testosterone levels suppressed. Can you give us some insight on why men may be vulnerable?
Absolutely. First of all, osteoporosis in and of itself is still a risk for men. And there's still, for all men over 50, there's still a 30% risk of an osteoporotic fracture in men over the age of 50. And interestingly, and unfortunately, men who get a hip fracture are much more likely to die in the first year than women are. If you look at the lifetime risk of prostate cancer, that risk is about 30% as well. So we hear a lot more about prostate cancer. But for those patients who are treated for prostate cancer, some of the medications actually put those patients at risk for osteoporosis as well. So while 80% of the patients with osteoporosis in this country are women, we certainly don't want to neglect the 20% who are men. And I think that men, as well as women, need to be attentive to adequate calcium, vitamin D, and exercise, as well as fall prevention.
And we need to remind people, as we said a little earlier, that corticosteroid use, regardless of the condition, whether it's rheumatoid arthritis or COPD, chronic obstructive pulmonary disease, or asthma. Corticosteroids are used for inflammatory bowel disease. There are just so many conditions where people have to take corticosteroids on a regular basis. Men as well as women may increase their risk.
Absolutely. And it's really important that obviously those prednisone or other steroids, for all those conditions, inflammatory bowel disease, COPD, rheumatoid arthritis, all the rheumatic diseases, those are really important and frequently life-saving. So I don't want anybody to think, this is bad, I shouldn't take it. It's just that you may have to take another medication to protect your bones from bone loss while you're on it. I'm glad you actually brought up COPD, because a lot of those patients have a real bad combination of issues. They're on glucocorticoids, they've been smokers, they have sedentary lifestyle, and they're on a lot of prednisone to keep them able to breathe. So that's a population of patients that we frequently see and treat for osteoporosis.
One other condition that may be associated with osteoporosis is celiac disease. Now,
yes,
it's probably much less common than COPD, but nonetheless, for the person who has it, it's pretty bad for your bones, isn't it?
Absolutely. Anybody with celiac disease or any other condition that may make you less able to absorb calcium as well is really a risk for osteoporosis as well.
Now, we've talked a little bit about supplements. We've talked about how important vitamin D is and calcium, but what about things like magnesium that's often forgotten? And we hear a lot about vitamin K. Any thoughts about those supplements?
Well, in general, the magnesium, unless somebody is not eating a well-balanced diet, most people's magnesium levels are normal. But if they're not eating a well-balanced diet, a small amount of a magnesium supplement may be helpful. Vitamin K is usually normal if people are eating a broad diet as well. But for those who aren't, some multivitamins that contain vitamin K may be important. It's important, though, that if you're on a medication like Coumadin or other blood thinners, that vitamin K not be supplemented without the discussion with your doctor.
Dr. Abelson, have you heard about strontium? There are a lot of people who think that that's sort of the magic sauce that will protect them.
Actually, strontium has been around a long time and actually has been available in Europe. One of the things that's, and it's certainly been looked at by our FDA as well, we don't recommend strontium in the studies. In some of the studies, while it may have increased bone density, it did not decrease the risk of fracture. So we don't think in the medical osteoporosis community about strontium as a magic bullet, and we go with what our FDA has approved and advised.
Dr. Abelson, SERMs, they've kind of fallen out of our vocabulary and out of interest. But the very first one was a drug called Avista, raloxifene. And it seemed to be the best of all possible worlds in that it reduced the risk of breast cancer while it was building up bones. Can you tell us what a SERM is and where does it stand these days with you and your colleagues?
Well, SERMs are selective estrogen receptor modulators. So they act just like estrogen in some organs, like bone. They build bone, but they are anti-estrogen in others, like breast. I still do have some patients on SERMs. I have a number of patients with osteopenia, for instance, who have a strong family history of breast cancer. They take it, and it does decrease the risk of invasive breast cancer while building up their bones. So there still is a role for SERMs, or the selective estrogen receptor modulators, in many patients in our practice.
You're listening to Dr. Abby Abelson. She's chair of the Department of Rheumatic and Immunologic Diseases of the Orthopedic and Rheumatology Institute of the Cleveland Clinic. She's also Education Program Director in the Department of Rheumatologic and Immunologic Diseases. Her book is The Cleveland Clinic Guide to Osteoporosis.
After the break, we'll talk more about the medications used to treat osteoporosis.
What should you know about bisphosphonates like Fosamax, Boniva, or Actonel?
And where does estrogen fit into the picture? And we'll learn a little bit more about drugs such as Forteo and Prolia.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like this podcast of The People's Pharmacy and want to continue the conversation, you can join us online at facebook.com/People's Pharmacy to share your thoughts or comments. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. 800-345-7339, online at uttercream.com.
To purchase a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1093. That number again, 800-732-2334, online at peoplespharmacy.com. You can also download the free podcast from iTunes or from our web store, and we invite you to consider writing a review.
Today we're talking about preventing osteoporosis. Although osteoporosis is usually a condition that strikes older people, both women and men. Prevention is a lifelong project. What can you do to maintain the health of your bones?
Our guest is Dr. Abby Abelson, Chair of the Department of Rheumatic and Immunologic Diseases of the Orthopedic and Rheumatology Institute at the Cleveland Clinic. She's also the Education Program Director in the Department of Rheumatologic and Immunologic Diseases. Her book is The Cleveland Clinic Guide to Osteoporosis.
Dr. Abelson, we have an email from Martha, and Martha says, my physician wants me to use Forteo. She says she'd use it for just 1 year and reserve the second year for later, followed by one of the other medications to maintain bone. The other medications I'd need to take after Forteo sound pretty risky. Even a small risk of damage to the esophagus is unacceptable because I'm a singer. I read statistics like, without medication, 50% of women over 50 with osteoporosis will break a bone. The article I read this in didn't say what the percentage is for women who do take the medication. That was omitted. And she goes on to say, my graduate degree is in mathematics. I've studied statistics. I need more facts. So what are the best drugs for someone like Martha who has just been diagnosed with osteoporosis?
Well, I think that Martha is raising a lot of important questions, and I'm so glad to be able to address them. First of all, the risk of fracture in her, it's about 50%. After treatment with medications, the risk of fracture is reduced by about 50 to 60%. I suspect that if her doctor has recommended Forteo, that her bone density was quite low. Forteo is the strongest medication that we have. The generic name is teriparatide, and it is an anabolic agent. It acts on the osteoblasts, the cells that build bone, and it is the one agent that is the strongest in terms of increasing bone density and probably is the most powerful in terms of decreasing fracture risk. The use of Forteo is limited to 2 years because in the early experiments with this medication in animals, in rapidly growing rodents, there was an incidence of sarcoma. And I'm sure that is what Martha is concerned about if she's concerned about Forteo. Again, your lifelong exposure to Forteo can only be 24 months, and so it sounds like her doctor wants to give her 1 year and then give her another medication. After Forteo, we usually give something. If you stop Forteo and don't take anything after it, you're going to lose all the bone density that you've gained. So her doctor has given her good advice that she'll need something after it. I think the category of drugs that might have been recommended is a bisphosphonate. A bisphosphonate works to decrease the rate of bone resorption, that is, to decrease the bone loss. The medications that might have been discussed with her might have been medications like alendronate, Fosamax, Beniva, Actonel, or the brand names. But I think her concern about her esophagus being a singer is really important because oral bisphosphonates, medications that you take by mouth, have a risk, not a huge risk, but a risk of irritating the esophagus. There are some IV medications, Reclast, and which is zoledronic acid, and Beniva, which is a bandronate, also have IV. So she could get one of these medicines that prevent her from losing bone after Forteo, IV. And frequently when we have patients who either have an underlying esophageal problem like Barrett's esophagus or some other motility problem of the esophagus, we will automatically go to a non-oral drug. So that might be an option. The other option might be something called denosumab, which is a biologic medication.
Well, before we get to Prolia, which is denosumab, I'd like to go back a step or two. You mentioned sarcoma, and our listeners may not know what that is. Okay. So although it's presumably quite rare with Forteo, and the newest one, which is How is that?
Abaloparatide.
Abaloparatide.
Timlos.
Timlos, yes.
I don't know if there's been any risk of sarcoma associated with that drug in animals. But what is sarcoma?
So sarcoma is a cancer of bone. When I was talking about it being used in rodents in the early tests, sarcoma is not seen in people. It has not been seen in people. But the 2-year mark is what the FDA is holding the duration of both those treatments, both abaloparatide and teriparatide, to no longer than 2 years of either because of the animal studies. But again, It has not been seen in people.
So you also mentioned bisphosphonates, and they were the first drugs that came along to either prevent or treat osteoporosis. And they were advertised very widely. I mean, I remember, I think it was Sally Field and her beautiful dog on television and talking about how wonderful, was it Boniva was? I don't remember. I've lost track of all those. I don't even remember
either, yeah.
commercials. But
you remember the dog.
I remember
Dogs
that dog.
Are great in drug commercials.
They certainly make the medication seem very appealing. But the bisphosphonates have been very controversial, Dr. Abelson. And the question about the bisphosphonates is stronger. Yeah, but maybe brittler, if there is such a word as brittler, but basically brittle bones, because we've heard of things such as osteonecrosis of the jaw and this really nasty thing that I am sure, scare every orthopedic surgeon, and that is atypical femur fractures. At first, nobody thought it could be caused by the drug, but now we know it does happen, although there's some question as to whether it's extremely rare, or more common than we'd like to think. So please give us your overview on this stronger but perhaps more brittle and the possibility of atypical femur fractures.
Absolutely. So when we first started using bisphosphonates, we didn't have long-term experience with it. We now know that bisphosphonates are generally quite safe and effective. They do decrease the risk of fracture by about 50%. We've done lots of bone biopsies in patients, and they produce normal bone quality. But for the most part, we will limit the use to about 7 years. The duration of therapy should be about 5 to 7 years. It's after this prolonged therapy that we start to see a higher risk of atypical fractures. And again, that's what you're probably referring to in terms of brittle bone. Again, it's very rare. Probably the percentage risk is similar to getting struck by lightning. So it's very rare. But we've learned that we will not keep people on these medications indefinitely. The other thing you mentioned of osteonecrosis of the jaw is probably even rarer. And that usually happens in the setting of a patient getting a tooth pulled and it not healing in well. Again, it's rare. If somebody has very poor dentition and is planning on multiple tooth extractions after discussing this with their dentist, we'll usually wait until those teeth are pulled and they've healed in well before initiating therapy. Again, both of these complications are rare, and they're much less rare than a person who has osteoporosis getting a fracture like a hip fracture. So again, we're weighing risks and benefits, but in general, if used for 5 to 7 years, bisphosphonates do not produce brittle bone. On our bone biopsies, they are normal bone with a good portion of really good architecture. And in general, osteonecrosis of the jaw is rare as well. I have been in practice for quite a long time. I've never actually seen an osteonecrosis of the jaw. And in all of my years of practice, I have seen one atypical fracture, and I'm not even sure that it was an atypical fracture when we've looked at it. So again, you really need to work with your doctor to see what your individual risk is. Now, those are the things that apply to the bisphosphonates. So when I was talking about teriparatide and abaloparatide, there really is not a risk of either of those two things with those two medications.
Probably the very first medication that was used against osteoporosis was estrogen. And women at one time, as soon as they hit menopause, were told you need to take estrogen to keep your bones strong. At that time, they were also being told you need to take it to keep your heart healthy. We now know it doesn't keep the heart healthy. It does keep bones strong, but there are limits to how long a woman should take estrogen. So can you give us your ideas on when estrogen might be appropriate and when it's not?
Absolutely. So in general, I recommend that women have this conversation with their gynecologist. Actually, the North American Menopause Society came out with a new 2017 position paper, and in general, they're recommending the use of hormones for women who are younger than 60, who are within 10 years of menopause, who have no contraindications like a close family history of breast cancer, for a short duration to treat those symptoms. But there still is the sense that prolonged therapy with estrogen still has a risk of breast cancer. And again, balancing the risks and benefits of these medications and your individual risk is really important to talk about with your doctor. I don't think that anybody can say what's right for every woman in this context. Some patients for vasomotor symptoms are on very low-dose estrogens, and in general, those are safe. And certainly for vaginal symptoms, some low-dose vaginal estrogen therapy are also recommended in this North American Menopause Society recommendation.
Let me throw in a translation. Vasomotor symptoms, commonly known as hot flashes.
Hot flashes, absolutely. Yes,
okay.
I think that, yes, I'm sorry.
One last drug we haven't talked about, denosumab, Prolia. Where does it fit in the picture?
So denosumab is a really important addition to the armamentarium of osteoporosis treatment. It's a medication. Denosumab is a biologic. It acts directly on the bone cells, and it decreases the activity of the osteoclast, so it helps maintain bone density and actually improves bone density and decreases fracture risk. It is given by injection once every 6 months in your doctor's office. In general, it's safe. Again, if it doesn't seem to have the long-term potential consequences that some of the bisphosphonates do. So I think that it is definitely an important option to discuss with your physician.
One or two quick questions on Prolia, if I may, and that is there's some impact on the immune system, and so some concern about infections, and some concern about the withdrawal effect, that once you stop Prolia, it may increase your risk for what's called vertebral fractions of the spine. Any thoughts?
Well, so Prolia actually has very few side effects, but if you go off of it after long-term therapy, within 7 years, your bone density will go down to where it was before you started the therapy. It is this loss of bone afterwards that might be associated with the fractures to which you're referring. There was a report in some of the clinical trials of an increased incidence of skin infections, but in general, those really are not serious infections. It's a very small number. We are still using it in patients who are immunosuppressed with other therapies. So in general, what I tell people is if you see that you're getting a small infection in your skin, let your doctor know. And again, just as with anything else, you have to weigh the risks and the benefits of any of these treatments. But even in patients on immunosuppressive therapies, we are in general comfortable with their taking Prolia as well.
Dr. Abelson, the take-home message for our listeners, obviously prevention is the number one best approach. It's much better to prevent a fracture or to prevent osteoporosis than trying to deal with it after the fact. What is your kind of overview of how to keep your bones strong and healthy?
My overview is that we should start talking to our children early about bone strength, making sure that they understand calcium and vitamin D and exercise and activity are the essential things to keeping their bodies and especially their bones strong, maintaining those habits throughout life. You know, the vast majority of people will not need any medical treatment if they attend to these preventive things, preventive modalities. But again, there's certain things you can't prevent. I mean, I had no choice with, the genes that I have a long history in my family of osteoporosis. It just means I need to be extra attentive to it, talk to my doctor about potential treatments. And again, I think that we have to be just as cognizant of our bone health as we do the health of every other organ in our body.
Dr. Abby Abelson, thank you so much for talking with us on the People's Pharmacy today.
My pleasure. Thank you so much, Joe and Terry.
You've been listening to Dr. Abby Abelson. She is chair of the Department of Rheumatic and Immunologic Diseases of the Orthopedic and Rheumatology Institute at the Cleveland Clinic. She's also the Education Program Director in the Department of Rheumatologic and Immunologic Diseases. She's written the Cleveland Clinic Guide to Osteoporosis.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. 800-345-7339. The website is uttercream.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1093. That number again, 800-732-2334. You can find it on our website. It's peoplespharmacy.com.
And when you visit that site, you can share your thoughts on today's show. You'll also find information at peoplespharmacy.com about some of the drugs we discussed with Dr. Abelson.
When you visit the website, you can also sign up for our free online newsletter or the free podcast of the show. You can listen at your own convenience or share it with a friend. And we'd certainly appreciate you rating our podcast at iTunes, Google Play, or wherever you subscribe. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you so much for listening today, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
When it comes to Father's Day, some things never change. Dads want steak. And the experts at Omaha Steaks are making it easy for you to deliver uncompromising quality with gifts that are sure to make his day. Plus, get an extra $35 off with code THANKSDAD when you shop omahasteaks.com today. We know being your dad means he already has everything he could want. But just picture the look on his face when he sees those extra-aged USDA-certified tender steaks, juicy air-chilled chicken, beefy burgers, and more. With carefully curated gift packages from America's original butcher, it's never been easier to show everyone why you're dad's favorite. And every bite is 100% guaranteed to bring a thrill to the king of the grill. Shop now at omahasteaks.com and get an extra $35 off with code THANKSDAD. But don't wait. Father's Day is June 15th. Minimum purchase may apply. See site for details.